All right, thanks for having me today, and I really appreciate the opportunity. I'm a professor at mechanical engineering at the University of Colorado Boulder. I've been studying urban air quality for 25 years. I'm also an expert on infectious disease transmission and mitigation, which is why I was tapped last year to help with understanding how to keep people safe from this airborne infectious disease. So let me start today by sharing with you a video that we made to help people understand how transmission of SARS-CoV-2 happens and how to keep yourself safe in indoor environments. The video includes my daughter. She's 14 and starting high school this fall. So let me move on to that video. Hopefully you can see my YouTube screen. I'm hoping, let's see. If I do this.
Yes, I can see it.
I'm trying to put it at the full screen. All right, do you see the full screen?
Yes.
All right, let's play it. Whoops. My computer's out. Yeah. Let's talk about transmission of respiratory infectious diseases. Respiratory infections are transmitted between two people when one is infectious and the other susceptible to infection.
When the infected person talks or coughs, they release a mist of particles made out of respiratory fluid that contains the virus. They can throw between 900 and 300,000 liquid particles from their mouth. These particles are less than 1 micron up to hundreds of microns in size. By comparison, the thickness of a human hair is about 100 microns.
One way to get infected is by contact transmission. When you touch a surface that has been contaminated by a virus and then touch your eyes or nose, you can get infected. There is not much evidence at all that this is the way you can get COVID-19.
The second way is when a spray of large particles, like a drop of rain, fly out of the infected person's mouth and land on your eyes, nose, or mouth. To get infected by this route, you must be close up to a person.
The third way you can get infected is by inhaling virus-containing particles that are floating in the air. This transmission route is called airborne or aerosol transmission. Some people think of an aerosol spray can of deodorant when they hear the word aerosol, but really an aerosol is just a bunch of particles suspended in the air.
Getting infected this way could happen by either being close up to a person, called short-range aerosol transmission, or when you're far away from a person, called long-range aerosol transmission. Animal studies, air sampling, and super spreading show that SARS-CoV-2 is transmitted by breathing in aerosols.
SARS-CoV-2 is an overdispersed pathogen like SARS and measles. This means as few as 10% of people transmit 80% of the infections, and many people barely transmit. Most infections happen within households, where 1 or 2 other people may be infected within your own bubble. Also unique to SARS-CoV-2 is that many transmissions are pre-symptomatic or asymptomatic, so you literally have no idea who is infectious. People are most infectious right before they have symptoms of the disease.
To prevent infections, we must control both short-range and long-range airborne transmission. Short range is when you happen to be in close contact. If you are as close as 8 inches, you can get infected by a spray of large particles landing on your face. Between 8 inches and 6 feet, you will inhale the virus.
Long-range aerosol transmission also happens. This is how super spreading occurs when you have a series of unfortunate events that happen all at once. A highly infectious person is indoors for a long time, shedding lots of virus, and there are also many susceptible people in the same space. The airborne virus begins to spread through the indoor space and builds up to high levels because there is poor ventilation, minimal surface deposition, and no air cleaning.
Why is this important? Because the way to minimize the risk is with different strategies. You will never prevent short-range aerosol transmission by improving your ventilation. The only way to prevent it is by wearing a good-fitting mask, staying socially distanced from the person and quarantining them from possible exposure, and definitely when you start to show symptoms. The closer you are to somebody, the more virus you will encounter, so try to stay at least 6 feet apart.
To minimize the risk of long-range aerosol transmission and super spreading, we must treat this with ventilation and air cleaning, and still wear masks to reduce the amount of virus that you breathe in or that you may release. Reduce the number of people indoors so that the chance that somebody is infected goes down.
You cannot ventilate your way out of short-range transmission scenarios, but you must ventilate your way out of a long-range aerosol transmission situation. And always use multiple strategies in case if one fails.
So there's my slide. And I just want to ensure that you know this was sponsored by the Sunnyvale Partnership for Healthy Schools and the Classroom Science-Based Prevention, which I think is fantastic. And thanks for contacting me. I want to talk just briefly about ventilation. Again, this is long-range transmission. If you're not wearing masks and you ever get close up to somebody, there is a potential of being infected, and ventilation will help you. But what we do with ventilation is we either use a mechanical system or a naturally ventilated system, which is just open doors and windows, which many classrooms have, especially in California. A study a while ago, and we've seen a number of studies to show that ventilation rates are too low in schools and they need to be increased. And this has to do with everything from learning to illness absences. So this was done by your California Department of Health by Mark Mendel, and they looked at classroom ventilation and illness absence. And they found that the predicted proportion of illness absence decreased as you increase your ventilation rate. And you could reduce the illness absences by 3 to 5% if you would meet the California standard, which many schools don't, of 4 to 7 liters per second per person. Now, we are recommending in a pandemic to have more ventilation than that. If you increased it to 9, you would reduce illness-induced absences by 7 to 10%. And again, the graphs on the right do show that the ventilation rates in the South Coast, Bay Area, and Central Valley are not great, and that the high CO2 levels also illustrate that ventilation is low. I want to explain air exchange rates. It's how we measure the outside air volume added to a space, and we normalize that by the volume of that space. We have a society in the industry called the American Society for Heating, Refrigerating, and Air Conditioning Engineers. For classrooms, they recommend 6.7 liters per second per person of outside air. So that's air coming in from the outside. The occupancy in a classroom is expected to be about 35 students per 100 square feet. So if you have a classroom that meets your design ventilation rate, that means you will be providing 455 cubic feet per minute to that classroom. Now, if you divide that by the volume of the room, that means for meeting the design standard, your air change rate will be 3 air changes per hour. That tells you something about how long it will take to clean the air of a pollutant or an infectious aerosol. So for 3 air changes per hour, that means it will take an hour for all the room air to be exchanged with outside air, and 20 minutes for just over half of the room to be exchanged with outside air. So on to the next slide, and hopefully you're seeing my slides advance. I want to share with you this study that was very important in trying to understand the relationship between airborne infection and ventilation rate. There was a tuberculosis outbreak at a university in an Asian country. And when this tuberculosis outbreak happened in the university buildings and the students, they realized that the buildings were poorly ventilated at 1.7 liters per second per person. That's very low. And the carbon dioxide levels measured in those spaces were upwards of 3,000 parts per million. Immediately, the engineers at the facility retrofitted the whole space at thousands of dollars of intervention to increase the ventilation rate. And they upped it to 24 liters per second per person, which is very high. And it also disrupted the outbreak of this airborne infectious disease. And the CO2 levels at this high ventilation rate were now about 600 parts per million, showing that there's this distinct relationship between long-range transmission of an infectious disease and ventilation in buildings. We want to think about, one useful tool to use carbon dioxide measurements as trying to determine whether you have enough outside air to ventilate your space. And this is kind of a nice graphic that my colleague put together where we have an infector who's releasing particles of virus, but they're also releasing carbon dioxide. So when you're releasing, you're breathing out or talking, you're releasing CO2 and particles. So the outdoor air does exchange particles with, does exchange CO2 with outside air. Outside air is about 415 parts per million now. An air cleaner in a space will only clean the virus. And that's great. So measuring your CO2 does not always help you understand how good your air cleaner is doing, but it will help you understand how much outdoor air exchange you're having in your space. So for example, measuring outdoors, you might use the sensor, you put it in your car, you're driving to school with your kids and it gets up to 5,000. That's because cars are poorly ventilated unless you open the windows or turn on the exchange with the ventilation system. And here you can get it down with your outdoor air ventilation. I want to point you to this study that came out about evaluating intervention strategies in schools for flu transmission. This was prior to COVID. I circle in yellow the interventions that work the best in these schools, and they were the three that are highlighted in blue. One is increase school and home ventilation rate to 5 air changes. Now, remember I said the ventilation rate in a design met school is 3 air changes. So we get this school up to and home up to 5 air changes. Home ventilation rates are very hard to increase, by the way. Or you do 100% isolation of all cases and you increase school and home ventilation rate to 5 air change. Or you do targeted isolation and increased school ventilation. And all of those had the same effect, was just like ventilation increased to 5 air changes was super critical. I want to point you to this resource. My colleague Joe Allen and his team put this together for the Harvard Chan School of Public Health. It's a great little piece of work that shows what schools could be doing to keep their environment safe. And I do hope all your school administrators have read this and are using it. Chances are they probably don't know about it, so you could help them find it. Quick on filtration. We now recommend that air cleaners are a great add-on to any space, even your home, especially during wildfire season, where they can recirculate your indoor air and clean it of particles. The thing you want to be careful of is the sizing of the unit. And we use the term clean air delivery rate to tell you what size of air cleaner to use in a space. So an air cleaner that's AHAM verified will have been tested independently by the Association of Home Appliance Manufacturers. I recommend an AHAM verified unit. I also recommend HEPA filter only, and this unit would clean 360 square feet with a clean air delivery rate about 250. We showed in our research that if you used an air cleaner, you could clean any kind of bioaerosol, including virus, fungi, mycobacteria, with an air cleaner. This little air cleaner that only had a CADR of 15 CFM was actually the sharper image unit that they were sued over and caused them to go bankrupt because it only cleaned 18 square feet, but yet it was quite expensive. This is the Harvard CU Boulder portable air cleaner tool that I put together with my colleague Joe Allen. For example, my local schools have used this tool to figure out what kind of air cleaner they should put in each classroom. So this is readily available on the internet for how to use it. And you put your classroom size in, you put in the clean air delivery rate of the air cleaner you're considering, you tell it whether you have low good, medium, or enhanced ventilation, and it will tell you whether the air cleaner will work for your classroom. I want to highlight the recent CDC study that does show that efficacy of portable air cleaners are great to help with masking, as well as masking. I'm super irritated at these school districts or these states who are not allowing schools to mandate masks. I think it's unsafe, and I think it's bad science and bad policy. For example, in this study, if you have no air cleaner, you would have high concentrations of virus. But if you have masks and you have air cleaners, then you can get those concentrations down low. And the reason I like the combination is that you're disrupting short range transmission and long range transmission. I'm just going to say quickly, electronic air cleaners are a no. They're aggressive marketing. They've sold millions of dollars of electronic air cleaners to school districts because they are very good at salesmen. They're telling you not true facts when they're trying to sell you these things. A recent study came out showing that the volatile organic compound concentrations are changed indoors when you run these electronic air cleaners, that they don't really remove particles very well, and that they're just changing the indoor air quality and not doing what they're supposed to be doing, which is to remove the airborne particles that have virus in them. Our own data show as well that there was nothing done when we ran an ionizer in our lab. The particle level stayed the same, and no effect was had on these expensive air cleaners. You need a lot of energy to inactivate viruses. You don't put that much energy in a real world environment, and you'll see possible byproducts, possible ozone. The literature is incomplete and problematic, and we just do not recommend. The last thing I want to talk about is ultraviolet light. We've done many studies to show that the use of upper room germicidal UV, which is 254 nanometer wavelength shown on this slide on the left, is very effective at damaging DNA and RNA. You hang these light fixtures in the upper part of your room, which is irradiating the upper zone of your room, and then if the lower part is free of radiation, and the room air is well mixed to inactivate the virus that's released in the occupied space. We recommend this type of approach when you have a space that has unsuspected cases, long occupancies, lots of people, and there's no ventilation or very minimal ventilation, or you can't use filtration. I've recommended them to the Seattle City homeless shelters, and you will see them in jails and waiting rooms and hospitals, for example. I do think there's some applications for schools. We've done our own research to show that there are things like lunchrooms and auditoriums where it might be a good idea to think about using this technology, but you do need to work with a certified, a reputable installer to design this kind of system. And they've been shown to disrupt tuberculosis and flu. So that's all I'm going to say. I'm happy to chat, answer questions, and thank you.